Hi, my name is Mike Pishfine. I'm a GI medical oncologist at Johns Hopkins University, and it's my pleasure to be a moderator here for a GI oncology tumor board. And I'd like to go around and introduce the panel. I'll start with Dr. Zev Weinberg from UCLA.
Hi, my name is Dr. Zev Weinberg. I am a GI medical oncologist at UCLA, Los Angeles, California. Nice to be here.
And then from Emory, Dr. Pritesh Patel.
Hello, Pritesh Patel, Associate Professor of Radiation Oncology, GI Radiation Oncology at Emory.
From Memorial Sloan Kettering, Dr. Martin Weiser.
Hi, I'm Dr. Marty Weiser. I'm a surgical oncologist and colorectal surgeon at Memorial Sloan Kettering Cancer Center.
And finally, from Washington University in St. Louis, Dr. Carrie Siegel.
Hello, my name is Carrie Siegel. I'm an abdominal radiologist at the Mallinckrodt Institute of Radiology at Washington University in St. Louis.
Well, thank you all for joining us. It's going to be some very interesting discussion about some exceptional cases, and I think we should go ahead and dive right into it. So this is a patient that we have, 48 years old, with a past medical history of paranoid schizophrenia, homelessness, HIV positive, with a CD4 count of 220, cirrhosis secondary to chronic hepatitis C, although that was treated. The patient presented in 2018 with abnormal imaging and concern for hepatocellular cancer with lytic lesions in the bones. However, the patient was lost to follow-up and re-presented in the emergency room in 2021 with altered mental status and imaging showing liver lesion as well as stable lytic lesions in the bones. The biopsy was done and showed hepatocellular cancer. So we want to talk about whether or not this patient is a surgical candidate, whether or not we would biopsy the lytic lesions, even if it was unchanged for 3 years, and then if not a surgical candidate, what would be our next treatment recommendation? So as far as the details again, so the patient presented to the emergency room in 2021, a few years later, with altered mental status that did slightly improve with antibiotics. The patient was a known cirrhotic with a Child-Pugh A score, although it was unclear if the altered mental status was attributable to the hepatic encephalopathy. The patient was interested in pursuing treatment, even though their performance status was 2. This medical history of paranoid schizophrenia, chronic hepatitis C, although treated, and denied tobacco or alcohol use, but did have use of IV drugs, and is currently homeless, although parents were living nearby and they were able to help when they could, and there was no family history of cancer. So again, the patient was seen initially as an inpatient by oncology for a potential hepatocellular cancer with a triple phase CT scan showing 3 liver masses, but also multiple pelvic lytic lesions. A biopsy was not done and the patient was lost to follow-up, but on the recurrent, on the representation, the triple phase CT scan showed a 3.3 by 2.2 centimeter lesion in segment 7 that did enhance arterially with washout or delayed phase without vascular involvement, but no ascites. Chest CT was unremarkable, and the bone scan showed the previously known lytic lesions. You can see the labs there. So Dr. Siegel, this is the triple phase CT from September 2018. What are your thoughts?
So on the image on our left, we can see a lesion that's hyper enhancing or brighter than the background liver. If we move to the image on the right, we can see a few fairly well circumscribed, punched out lytic lesions in the pelvis. If you move forward one slide, here we are, and you can see that on a portal venous phase, this lesion is now washing out. It's lower in attenuation compared to the background liver. And again, it's about 2.5 to 3 centimeters in size. So lesions that are arterial enhancing, washing out, and greater than 2 centimeters in size are usually LR5. It's a very good look, a very specific look for an HCC. Now, if we talk about the bone lesions that are unchanged for 3 years, one, it'd be unusual for HCC to have metastases that would be unchanged for 3 years. 2, it's unusual for HCC to metastasize to the bone. And 3, the rare times where we do see HCC metastasizing to the bone often there's a soft tissue component to the bone lesions. And as I had pointed out on the slide before, they're very sort of specific, just sort of punched out lesions. So I don't think these are metastases to the bones. What could we do to further follow up these bone lesions if somebody wants us to? There's a couple things we could do. FDG-PET is more sensitive than bone scan, especially in tiny lesions. That's one option. And option two, if the clinical team were to desire this, would be a CT-guided core biopsy. But my guess is those are not bone mets.
Which really brings us to the next question for Dr. Weiser. And I know this question can go in a lot of different directions and there's a lot of arrows to the algorithm, but can you give us your current perspective on who is a surgical candidate for HCC?
So the lesion is not particularly large and the liver resection wouldn't be difficult. However, you would have to assess the patient's liver function, degree of cirrhosis to determine if indeed they are a surgical candidate. I think that would be the limiting factor.
And would the biopsy of the lytic lesions in the bones be critical for you to make that decision for surgery? Or obviously Dr. Siegel's clinical radiographic impressions of these are not metastases. So what would you push for if you were on the team there?
So I would agree with her assessment. It is quite odd that they haven't changed in 3 years. I think it goes down significantly. Although not common, we do see some bone lesions with this disease. I would probably obtain a biopsy before surgery.
Okay. And then let's assume, just for the sake of this discussion, that the patient was inoperable but non-metastatic. Dr. Patel, would there be any role for radiation therapy or radio or chemo-embolization?
I think absolutely. We'd certainly have a tumor board discussion. I think it's a big topic, but liver transplant might be a consideration. But for a lesion over 2 centimeters that we think is in this case biopsy proven HCC, external beam radiation, Y90 or internal radiation or chemo-embolization really all tend to be excellent options with a good chance for controlling the lesion in question. The fact that there were 3 lesions seen initially is an ongoing, I think, question mark as to what happened to the other 2. Do they need to be followed? And sometimes that can make the decision between whether you would give an external radiation treatment, which is much more pinpoint to a single lesion like the one we're seeing, versus chemo-embolization or radioembolization, where you can really target an entire region of the liver. And if you have multiple lesions that you're worried about in a single region, then in that case, a regional therapy like an arterial chemo or radioembolization may be preferred.
So let me put Dr. Weiser and Dr. Patel on the spot here a little bit and present a hypothetical case. Let's say a 2 centimeter lesion that we know is HCC, but the patient is absolutely not an operable candidate, but it's just one single lesion. And we've got, as you said, probably 3 or 4 therapeutic options for that patient, whether it's radiation, stereotactic radiation, intra-arterial therapy of some kind, or even an ablative therapy. Do you have any preferences?
Well, we would fight over this at conference, everybody wanting their modality. I think they're all quite reasonable. Yes, so we're a fan of Y90, but also with external radiation and chemoembolization, I think they're all valid.
Gotcha. Okay. Yeah, that's probably exactly how it would go. Is it would depend on the tumor to board discussion. All right, then Dr. Wainberg. So if this patient did have biopsy-proven metastases in the bones, or for the sake of argument, any other unequivocal metastatic disease, what's your current treatment paradigm for a patient with metastatic HCC?
So, I mean, obviously, I concur with everybody's opinion. I think additional imaging is needed. Maybe even a myeloma workup might be considered in someone with an unexplained number of lytic lesions. But this case is very unusual. If there is documented evidence of metastatic disease with hepatocellular carcinoma, the new standard of care that has evolved in these last few years has been the combination of atezolizumab, bevacizumab, which had an improvement in survival over sorafenib. And if possible, if that's an available option for patients, and there's no contraindications to PD-1 inhibitors or immunotherapy or bevacizumab for that matter, that would be something to consider, certainly with Child-Pugh A metastatic hepatocellular carcinoma.
And then if the patient was ineligible for immunotherapy?
Then I would consider a TKI, a kinase inhibitor, and certainly there are a number of those. I should mention that we would only do this if there was metastatic disease, and certainly not after ablation or radiation or surgery for that matter. There's no real compelling data to do that at this point in adjuvant therapy for HCC. But if there was evidence of metastasis and a patient was contraindicated to receive immunotherapy, you could use any number of TKIs. There's sorafenib, there's certainly data with regorafenib, cabozantinib, lenvatinib, and you know, all of them essentially have met their endpoints in various phase 3 studies.
Yeah, I thought it was interesting kind of going back over this data, especially with regards to sorafenib. In the original sorafenib study from 2007 or 8, I forget, the response rate was 2 or 3%, but in both the atezo-bev versus sorafenib as well as the lenvatinib versus sorafenib studies, that response rate for the sorafenib control arm was actually upwards of about 10 to 12%. In general, what are your thoughts on achieving a quote-unquote response, actual tumor shrinkage for a patient with HCC, and how important is it?
You know, it's controversial. I think that, you know, people measuring response, and Dr. Siegel could probably comment on this better than me, but measuring response in patients with HCC is a little different than measuring radiologic responses sometimes in adenocarcinomas, in that the tumors manifest differently. I think some of it is a product of better patient selection, to be honest with you, and we've come a long way in HCC diagnostics in the last 15 years or so. And since the newer wave of studies has come out, response rate is not necessarily the most important thing in this disease, as it is in perhaps other adenocarcinomas, I will say. I should also mention that, you know, as we all know, cirrhosis dictates prognosis often as much as the underlying malignancy itself.
All right, so I think our panel recommendation for this patient is that, first of all, the patient is probably a surgical candidate as long as the liver function supports that, because those lytic lesions are so unusual that they haven't changed over 3 years and just in general for HCC. But that if the patient was not a surgical candidate, that if local therapy could be offered, and there's several paradigms that could be given for a patient with a single or just oligometastatic disease within the liver. But if for a patient who had clearly advanced metastatic HCC, then there's a number of therapies, but probably the current standard of care is atezolizumab and bevacizumab if they are available, or one of the tyrosine kinase inhibitors such as lenvatinib or sorafenib.